Great. Well, thank you, Brian, and thank you for hosting this. And first, I'm going to start with an apology for not being there. I was so looking forward to it. It's the first one I've missed in a while, but I hear it's going incredibly well. And thank you, Patrice and Eric and John and the whole team that makes this possible. So yeah, as mentioned, I'm going to be talking about this decision tree and really talk about Chiari from 30,000 feet. I do think it's an important topic because we can get into the weeds with Chiari, but I think really at the end of the day, as a patient and really as the physician, it comes down to, how am I going to treat this patient and what's the best thing for this patient? And oftentimes, especially in medicine and neurosurgery, there's a gray area. So there's a lot of controversy. We wouldn't be having these conferences and all the papers we've written and studies we're doing on Chiari if there wasn't. And, the Chiari comes from the beginning of definition. Every, I would say 5 years or so, there's a new definition. We go back to the old definition. We're adding something, we're combining something. So I don't think we've really even come up with a perfect definition yet. It's also incidental, meaning there are lots of patients that are diagnosed with this completely incidentally that are asymptomatic. And it doesn't mean that they need any form of treatment other than being aware that they have this. And the symptoms are very common. Headache, millions of people in the United States suffer from headache, and millions show up to the ER. It's one of the most common complaints that an ER physician sees. So the symptoms of Chiari, also the obvious ones, are quite common. The age difference, we're only starting to realize now that there's a difference between the pediatric and adult population, which used to be a big source of debate. And then treatment, who and when to treat. And just getting back to the pediatrics, our very own Bob Keating at Washington Children's, we were very fortunate and honored to be part of this paper that he published in the Journal of Pediatric Neurosurgery, showing exactly that with real data from multiple centers and lots of patients from the pediatric to adult population. So, as we've come along and really looked at Chiari closer, we're starting to get a better understanding. So let's start with what constitutes a Chiari. A Chiari is technically radiographically, anytime there's 5 millimeters or more of descent of the cerebellar tonsils, it will be classically defined as a Chiari or low-lying cerebellar tonsils. In pediatric population, other populations, it can go as low as 3 millimeters. A syrinx, low-lying tonsils with a syrinx. There's debate with syrinx alone, especially if it's just upper cervical. Cine flow, which I'm going to talk a little bit about, the flow dynamics, obstruction of CSF, even though there's not a really obvious large Chiari. And then symptoms, symptoms being a big one, which I think we as physicians are only catching up and finally listening to patients and realizing that some things that we didn't really traditionally understand as a Chiari-related symptoms are now starting to realize that they are in fact related. So a Chiari, that decision tree, and as a patient, which way do you go? But also from the perspective of the treating physician, making these decisions to really give the patient the best outcome possible. So it comes down to who should have surgery and who shouldn't, because at the end of the day, treatment for Chiari is surgical, and that really is the ultimate decision. And some salient points that I think are not always obvious to everybody is that not every patient with a Chiari needs surgery. It's okay to have a Chiari malformation and be followed and not have treatment or surgery. Patient being informed and part of the decision is absolutely critical. I've been doing this almost 30 years now, and I can tell you the biggest source of discontent is that lack of communication. And maybe the physician feels like there's an understanding, but there's not. Some of the patients are afraid to ask questions or challenge. So those are all things that are critically important. And then the correct diagnosis of symptoms. I mean, that's really what it comes down to. We're not treating MRIs, you're treating a patient as a human being, and you have to take a holistic approach of those symptoms and do they correlate with the Chiari? Does the whole picture make sense? So symptomatic Chiaris, and we'll start with that. Usually someone comes to the doctor or comes to clinical presentation by having certain symptoms. The most common are pain related. And I think in general, pain is something that brings patients to the doctor sooner than later. Headache is by far the most common. And we traditionally thought of the occipital, Valsalva type headache. And I think there still are many physicians who, it's not Valsalva, it's not occipital, it's not related to your Chiari. Well, we know, and I'm sure many of you listening as patients know, that's not true. There's virtually every single variation of a headache. Now, there are migraine symptoms that clearly have to be separated, and we'll talk a little bit about that. But neck pain, girdle, arm, and leg in that order are the most common. And really headache and neck pain, shoulder pain are the most common pain-related symptoms. Now, symptoms that aren't related to pain, weakness. And it's always amazing to me how sometimes patients who have just weakness or kind of gotten through pain will just live with it for a while until it becomes debilitating. It usually starts in the hands and arms and upper extremities. People notice they drop things, coffee mugs. Back in the day, it always makes me feel old when I ask patients and I have to remind myself, like using keys and fine motor. Most people don't use keys anymore because everything is, electronic and self-start. Numbness, same distribution. Arms, it can be in the shoulders, it can be in the waist, with the syrinx, the traditional cape-like distribution along the scapula and back. Loss of temperature sensation. And these are usually later findings. And you'll see patients that will have burns on their hands where they're frequently burning themselves and they're slowly losing temperature sensation, which they don't realize. Unsteady gait is probably one of the more common, along with weakness that's not related to pain. Double vision, difficulty swallowing, which is a big one, which I think difficulty swallowing is probably much higher than 8%. These all come from studies. Difficulty swallowing, a lot of times physicians don't ask about that. And when you ask the patient, they'll be like, hey, I am starting to notice that. And I never really thought anything about it. Ringing in the ear, again, I think is a very common, either in one or both ears. And then I think one of the things in the pediatric population that gets missed a lot is syncope, blacking out, fainting episodes, things like that. And then other more rare things like hiccups and sweating you can see as well. So signs, these are things that we see when we're examining you or that you may see yourself. Nystagmus, where the eyes beat, and it's typically a up and down motion, which is very common, especially with progressive Chiaris and some brainstem stretching. Difficulty with your gait. Maybe if you don't notice it, we'll see it when we have you walk up and down the hall. Clumsy, frequent falls, bumping into walls. Hand atrophy. You'll see the hands, particularly the kind of fat pads on the thumb, which will start to really thin out and flatten. And then the weakness, especially in the arms. We talked about the sensory, and then some of the things we'll see, or sometimes the patients will see, are fasciculations, which are these little kind of tremors of the muscle. Now, one of the big ones that we've in our center have started looking a lot at in the last 10 years are things like fatigue, depression, and particularly memory loss. And I've been guilty of it, in the past. There really was no direct correlation with memory loss. And when you're diagnosed with something like a Chiari out of the blue, you're having long-standing symptoms, people can't make the diagnosis, you start to feel crazy. It's almost 100% where you're going to start to have depression. You're going to start to have, fatigue and just lack of energy and overall just dysfunction. The memory loss, again, just because of our traditional thinking of pathways in the brain, we didn't really correlate. All these things are real, but they're a constellation of signs and symptoms. Things like misdiagnosis or poor communication make it worse because the symptoms that you as a patient feel are obviously very real. And if they're not taken seriously, or there's, again, misdiagnosis or poor communication, it makes it worse. Education understanding will reduce and relieve that. But one of the things that we started to look at now with the advent of more sophisticated imaging, particularly functional MRI, and diffuser tensor imaging, which can actually look at pathways via MRI. We now know that there are pathways in the brain, and particularly in the mid portion of the cerebellum and the vermis, that are responsible for memory, concentration, and executive tasks, which actually fits. We're starting a study now with our colleagues in radiology to start looking at pre and post, and also we're doing certain memory exams pre and post Chiari decompression to see the correlation and really hope to see what patients that are higher risk for this. So I think there's no truer saying than Chiari malformation and diagnosis of the devil's in the details. Again, we talked about headaches. There's over 100 different types of headaches. So if you talk to a headache specialist, a neurologist who treats headaches, it's amazing the variation of headaches and the treatments for them. And sometimes it's as simple as eliminating something like chocolate. And other times it's, multiple treatments, including up to infusions. But those clearly have to be separated out from an incidental finding on an MRI. Pain is very common in the Chiari, like we mentioned, but it has to fit a pattern. It can't be my whole body hurts. It can't be, in a distribution that doesn't make sense. That is one thing that God created us in a way that the patterns of the nervous system, the dermatomes always fit. Weakness needs to be specific as well. Again, you have to differentiate specific motor weakness from lethargy, from decreased generalized weakness. And really at the end of the day, if the symptoms don't correlate, a good result from intervention from surgery is really unlikely. And I think if you go back and you look at every patient that didn't improve from their surgery, in retrospect, I think you'd be able to go back, and a great majority of them, there would be a disconnect from the signs and symptoms and the Chiari. Another one of again, and this is an opinion of mine, but I can tell you from my and other colleagues' experience, if the first surgery doesn't help, the diagnosis needs to be questioned. Now, I have to be very careful with saying that. That doesn't mean that multiple surgeries for Chiari are common, and it doesn't mean that the initial diagnosis was wrong. But if there's absolutely no improvement, even in the first few days, weeks thereafter, that's when you really have to look at a diagnosis. And oftentimes it is multifactorial. So again, facts and thoughts, 30% of patients with a Chiari have complete asymmetry. And if you look at all the patients with Chiari, that number is fairly high. No one dies of a Chiari. And when I first see a new patient, it's the first thing that I want to reassure them. And when I say that, you see there's an asterisk to that, because there are cases, severe cases with severe brainstem compression, children who go apneic, who stop breathing, things like that. Those are extremely rare. But I think the first thing is reassuring the patient that this is not a diagnosis of a end-stage cancer. This is not something that is not treatable. And again, it's working with the patient to come up with a solution to help the signs and symptoms and differentiate between surgery versus non-surgery. And the other very important thing is, understanding surgery is not a trial, it's permanent. So when we try different medications, oftentimes patients don't want to take medications, which I don't think is a bad thing. But at the end of the day, I always remind people, you try the medication, and if it doesn't work, you stop it. If you're having side effects that are worse than what you're being treated for with the medication, you stop it. They reverse, they go away. Medication doesn't cause permanent symptoms. So surgery is very much unlike that. Once you have surgery, it's permanent. And whatever repercussions from that, whether it's a complication of the surgery or not, you're changing the pressure and fluid dynamics in the brain, which can have different effects. So you have to choose the treatment for the condition, not the symptom. And then the degree of herniation, again, I would tell you, I think, and we're going to go through some real-time cases to I think that's the best teaching tool. An illustrative tool, doesn't always clinically correlate. And I can tell you, every surgeon that treats this and everybody at this conference, have treated patients with minimal Chiaris with severe symptoms that have completely resolved, and then patients with incredible looking MRIs that are horrific looking, and they're really relatively or completely asymptomatic. So it's important to know that the number is a guide. So your initial visit really comes down to who to offer surgery to. I think the most important, because as a surgeon, patients are coming to you for that decision, who to follow. And we'll talk a little bit about what that means. I'm not a fan of, well, you don't need surgery. I don't know what to tell you, go see a neurologist. That does not help the patient, especially in today's age where you're having a 6-month, and I can tell you in Philadelphia, it's up to a year wait to see a neurologist. And that's not an exaggeration. And again, who to help, meaning who needs that help to be able to pick up the phone, call a physician, say, hey, I need you to see this person for this. This is what I'm concerned about. I've ruled out surgery, but this is what I want you to focus on. And again, patient selection is any tenet in any surgery. And it takes a team. My team, if you see, the team I'm showing you here are not surgeons. Cognitive neurology, Parkinson's, neuropharmacology, neuropsychology. It's a whole team of people that are also treating the patient, even though if it's made with or without surgery. So thoughts to summarize that. Adult and pediatric are not the same. And again, we have that great paper now. Actually, we have data to it. Age is not a limitation. The oldest patient I operated on was 87, who was complete independent, active, driving, walked a mile a day, and was in a wheelchair, had a significant Chiari, and was able to ambulate, did not need a wheelchair anymore. So age really is not a limitation. Every case is unique. And again, a big message of the general population, if you did an MRI on everyone in the country, 1% would show a Chiari. So that's a minimum of, it's now 3.6 million people who have an incidental Chiari. So let's talk about patients. So let's start with, and these are real patients of mine over the years who I think are great illustrations. JS is a 25-year-old female who came in to see me. She was diagnosed with a Chiari by her primary care doctor because she was having severe neck pain. They got an MRI. She had complete lack of energy. Her neck was absolutely, she'd wake up, go to bed in pain. She had debilitating headaches. So where after talking to her, they were around her period where they got worse. And again, to the point where she would have to leave work, which was even more stressful for her and causing her stress because she just started her dream job. This is her MRI, and you can say this is something that I would probably characterize more as low-lying cerebellar tonsils. You can see the red arrow here than a true Chiari. But again, getting back to what we were talking about, her office visit, talking to her and listening to her and getting some history, the first thing that I realized was she's in an extremely high-stress job. Yes, it was a job of her dreams, but probably she bit off a little bit more than she could chew. So she was stressed out with that. She wasn't sleeping well. She was getting about solid sleep, 2 to 3 hours of sleep a night, and then waking up with this neck pain. Her neck was tender to touch when I saw her. That's a big, big sign, because when you can reproduce, push on a muscle and it hurts, that's muscular pain. That's not neuropathic pain. Now that you can have both, but that's a huge red flag to me that, okay, there's something going on here with either positioning or compensating for something. So going on more about her headaches, again, they're around the time of her period, but also very photosensitive. Loud noises made it horrible. What makes it better? Lying down in a dark room. That's the only thing that makes it better. And ibuprofen, much more so than Tylenol. That's classic migraine. And then asking her more, her mother had a history of migraines. And as a child, in her young, early preteens, she had migraines and then they went away. Classic pattern for migraines. So her exam, completely normal. So she was hyperreflexive. That's normal in a young female. So the plan, she has a Chiari by definition. Should I operate on her? Well, I think the answer is no, because we started looking at the symptoms that didn't fit. Her headaches resolved after she went on migraine therapy for it. She changed her sleep habits, which the biggest one was that she basically got a orthopedic pillow, a memory foam one. And then she basically changed her job. She stayed at the same company, but she took a different position and started doing meditation. And I saw her 3 months later, literally every one of her symptoms resolved. So, getting to the point of the low-lying cerebellar tonsils and the MRI diagnosis of Chiari, it's important to realize that there are variations on every hour in a patient's, it's a dynamic movement. It's not something that's fixed like bone. So this is MRI difference of a patient in an upright sitting MRI and lying down. Look at the degree in the sitting versus the lying down. There's a substantial difference. That's a difference between saying Chiari, no Chiari. So the point of this is that you have to account for variation. So again, just because something is 5 millimeters doesn't mean that it's always 5 millimeters. And then cine flow. I mean, this is a picture that we talk about it all the time, but this is just a great illustration of what it is. And you can see the white here, which is the cerebral spinal fluid going around the foramen magnum in front and in back. And again, what is the goal of Chiari decompression? It's to remove this bone and open up the flow of CSF and decompress here. If you have wide open CSF going, it doesn't matter what the descent is. Surgery, you're not going to make that CSF flow any better by doing surgery. So it's an important tool. So let's go to another patient. So 42-year-old, mild headaches, noticed that she was dropping objects, particularly her coffee mug. She had one of these big Yeti coffee mugs every morning. She started dropping it. First, she thought, oh, I was being clumsy, kept making up excuses. And then it started to become a very consistent thing to the point where she had to hold it with 2 hands. Was having neck pain and started to feel unsteady, especially going up and down stairs. And again, otherwise a young, healthy female. Her MRI showed this. So this is a very, very significant Chiari. And you can see there's no white here. There's no cerebral spinal fluid at all. I don't need to do a cine flow here. I know what a cine flow is going to show. I can see on a static MRI, there's no CSF. So yes, the box is checked for Chiari radiographically. So let's see in the office, going through the symptoms. So I'm further questioning, which she never really mentioned to her primary care doctor. She was having ringing in her ears, probably about a year prior to these symptoms, was having difficulty swallowing within the last 6 months. And her headaches were no photophobia, much, much worse when she was doing anything that strained, particularly lifting, which she did a lot with at work. And it was her whole head. And she described it as a water balloon that was going to pop. On exam, she had severe hand intrinsic weakness and she had atrophy. She had a decreased gag reflex. She was ataxic when I saw her walking. And again, keeping in mind, this is a 42-year-old who's normally healthy, otherwise healthy, should not be walking with a wide base gait. So her plan is surgery. Signs, symptoms fit, imaging fits. And so this is a clear-cut patient that needs surgery. And you can see where once the decompression goes, the symptoms all get better. Now, do all the symptoms get better day one? No. Usually, and I'll tell my patients, the first thing that you'll notice that will get better pretty much day one is the headaches, that pressure sensation, the ringing, gets the ringing in the ears, difficulty swallowing, all that followed. Then lastly is motor strength. Motor strength takes a while, particularly when you start to see hand atrophy. And then last is usually the sensory, but not in all cases. So what are some other associated conditions that also are Chiari? It's very frequent to see, and I quote 10% to my patients, that the underlying cause of the Chiari is hydrocephalus, which is an enlarged ventricular system. And oftentimes this is from birth, and over the years and decades, patients compensate for it because as those ventricles start to expand and the pressure increases slowly, there's a slow pushing down through the foramen magnum, which then secondarily causes the Chiari and or syrinx. So here's a patient that I saw recently, 23 years old, who was blacking out, was literally just syncopizing, blacking out at any different times of the day. She had positional headaches. Her headaches were worse in the morning when she woke up, and particularly when she was lying down. She had double vision when she was driving, and her neck was stiff. Not palpable stiff, but just overall very, very stiff. This is her MRI, and this is a 20 and CAT scan. This is a 23-year-old. These are very big ventricles for a 23-year-old. They're not something like you see in some of these congenital hydrocephalus, but this is very large. This is hydrocephalus for a 23-year-old, particularly given her symptoms. And so she also has the Chiari. You can see there's a Chiari here. So in this case, and especially based on her symptoms, we treated the hydrocephalus first with a shunt, with a very clear plan that if things don't get better, we're going to proceed with a Chiari decompression. And she fortunately did very well with the shunt alone. All of her symptoms got better. And I'm actually waiting for her follow-up to look and see, because we do have some patients where the Chiari anatomically will actually get better. Sometimes they don't, but often they will. But it almost doesn't matter, because the CSF and the pressure-related phenomena are causing the symptoms. Now, this is somebody who I just treated a couple of weeks ago. So this is another young gentleman, 34-year-old, who had severe debilitating headaches, but he also started to have visual loss and blurriness of his vision. So he had I sent him to an ophthalmologist. He had papilledema. He had swelling of his optic discs. So this is pseudotumor. So you can see the brain is so full. The ventricles are small, but you can see how full that brain is. You think of a sponge that's waterlogged, and that's what this is. And so for him, his treatment was an LP shunt for the pseudotumor. Again, all the symptoms went away. And he has, albeit small Chiari, but again, he was sent to me for Chiari decompression. But the diagnosis radiographically was correct, clinically was not. And the treatment, therefore, was different. So in general rule for hydrocephalus, you really have to rule that out in every Chiari patient. You need some type of cranial imaging, whether it's an MRI or just a CAT scan. I treat the hydrocephalus first, unless there's exceptional circumstances where some of the things are clearly more brainstem. And if a patient of mine has multiple leaks, or I get a second opinion from somebody that's had 2-3 leaks after the dura's open during surgery, that to me is Chiari every day hydrocephalus. And you're not seeing it in the CAT scan because it keeps decompressing. And you think of sewing a patch in and then filling that water balloon up, and it's just going to keep blowing out the path of least resistance. So I'm not going to get too much into the treatment for time's sake. I'm sure you guys have had some excellent talks, but the treatment has really changed over the years. We're working up a series now of a minimally invasive procedure where we don't do a Y incision anymore. We do a linear incision. And the craniectomies have gotten smaller and smaller and smaller. There's just removing enough bone here where we can open up that foramen magnum. And my goal for the surgery is really to just think of the sine flow, blockage of CSF, opening of CSF. And again, this is the clinical picture where we take off that ring of C1, and it's really to give us more room. And more times than not, these cerebellar tonsils are very low. So you want to get I stop just when I can see space of CSF here and I can start to see the spinal cord. That's when I will shrink these tonsils with bipolar cautery. We don't cut them. We gently shrink them. They shrivel up to here, and then we close this dura. And I think and again, this is an assumption on my part. I don't have data yet to prove, or I don't know that we'll ever have data, but I think the biggest source of the CSF leaks, which is the most common complication of opening the dura and putting a patch in, is this Y incision that we do. And it's really up here where it gets very difficult to get a tight closure. It's a very awkward closure, and it's rarely down here in the linear component to it. So we started making just from here to here linear components, opening this up and then closing primarily, or putting in a small like Band-Aid patch. So you can see the goal is the decompression to go from this, and here's an intraoperative picture, and you can see there's the cerebellum, there's the tonsils, that's C1 gone there, C2 below. This is where I'm done. I can see the bottom of the tonsils. I don't want to just close this up because you can see all this tissue stuck in that area where the blockage occurs. So that's why we like to not just shrink, but flatten these just to allow CSF to circulate much easier. One of the newer things we're doing now, which is a whole talk into itself, is we're using these clear fit plates. And I never in the past put any type of mesh or plate. I didn't feel the need to. What these allow you to do is take an ultrasound, and now we're in the office. Somebody's having symptoms, and delayed. We can just do an ultrasound in the office and see that cine flow by a simple ultrasound. It really is a game changer. These are some pictures of that. These are ultrasound pictures of a Chiari showing in the office how we can do this, and it gives you real dynamic, real-time picture right in the office. Syringomyelia, again, the correlation with this, I think when you get into the decision tree, I want to talk a little bit about this because this is another huge source of, I think, confusion for everybody. Syrinxes have to be related to a Chiari to manifest any type of decompression. I think some would even argue to require any type of surgery without rare circumstances. This is a classic. And I think this is an indication for surgery. If there is a clear Chiari and you have this classic cervical syrinx every day of the week, that requires surgery. This is not going to get better, and about 80 to 85% will get better clinically and radiographically with the decompression alone. But when you start looking at things like this, where there's these linear syrinxes, this is a residual after a decompression, and patient symptoms completely went away. You don't necessarily see them always go away. And not all patients with syrinx need to be treated either. This is actually somebody who, this is my patient Gia. So she's 71. It's now 20 years ago. This slide's 5 years old. She came to me with a Chiari and this linear early syrinx. The only thing she had was tingling in her feet, but she was diabetic and otherwise asymmetric. She absolutely refused surgery. And I recommended surgery very strongly, actually. Every year she comes in, always bearing gifts. She's the sweetest woman in the world. And to this day, she's never needed surgery, and she's really gets a yearly MRI and doesn't need surgery. So again, every case is a little bit different. So here's a 56-year-old who had a major motor vehicle accident, 29 years old, severe, lost consciousness, was medevaced, had a spinal cord injury, and came in delayed with severe burning pain around his chest, no other symptoms. He made a really great recovery. And this is what he had. This is a traumatic syrinx in the mid thoracic spine. This is not going to be treatable by any type of surgery. Even putting a shunt in there, there's all different types of things we do. And I can tell you over the years, the recurrence rate is very high, complication rate's high, and most of these patients don't get better. So I'm going to kind of close out with some facts. 70% of syrinx are associated with a Chiari, but the 30% that aren't are a different entity and a different beast and require different types of treatment. You always have to rule out a cystic tumor with an MRI with gadolinium. Trauma, you always have to elicit a trauma history, things like basilar invagination. I know there's a great talk about that now. And again, these are the types of things that we're talking about. So I'm not going to get too much into this, the pathophysiology of it, but I do want to give just some parting advice. You're your only proponent, and that goes for anything in healthcare. That goes for us and family members of us as physicians as well. You are your only proponent. Speak up. Ask questions. Don't be afraid to ask questions. Make your doctor explain everything to you. And if you don't understand anything, make it very clear. And more times than not, if you keep asking something that's not clear, the doctor's not explaining it well. It's not you. Don't be afraid to get a second opinion. Any doctor that gets upset if you're going to ask for a second opinion, I think is a bit of a red flag. Internet's not a bad thing, but it's only as good as its source. And the same thing with second opinions. When you get into third and fourth and fifth, that turns into confusion for everybody. So getting a second opinion, and if it's a really complicated case, a third opinion is not a bad thing. My treatment paradigm, symptoms first, MRI second. I do not treat MRIs. Really, the symptoms and imaging have to correlate. Early symptoms with a mild Chiari, I follow very, very closely. This isn't an acute disease. I tell my patients, you're not going to wake up paralyzed. We can watch this closely, especially if they're good patients are going to follow up. No symptoms or signs, no surgery. I don't care what your MRI looks like for the most part. Anything that has motor weakness, especially in the hands, balance, brainstem findings, we're going to recommend surgery. Syrinx with a Chiari, I'm going to recommend surgery. So in conclusion, symptoms of a Chiari are multifactorial. It's not one size fits all. It takes time between the patient and physician relationship to really come to the best plan. MRI findings do not always correlate with the symptoms. Chiari is a treatable and curable disease. When I see my patients post-op, and certainly after a year or two when the symptoms are gone, I tell them, you don't have a Chiari anymore. Now, it doesn't mean they can't have recurrent symptoms. It doesn't mean that the Chiari can't recur, but it means that that Chiari anatomically is gone. And it's a really important point for patients to understand. And again, be vocal and be your strongest or your family members or loved ones' strongest advocate. And I will close with that. And I'm happy I can take any questions at the end or whenever it fits into this session. Thank you.